It's a pleasure to be here. My name is Gary, and I'm going to speak to you about what I've learned in the past 11 years studying just TFCC tears. I wanted to let you know that we have a lot to learn about the dynamics of the wrist, and there hasn't been significant change in the treatment of TFCC tears since I started 25 years ago. And I've learned quite a bit from a large population of patients with TFCC tears. I took a sample of 190,000 cases in this picture of people that have come to the website. Sorry, I'm looking at the wrong page. Since 2006, we've seen 500,000 cases of people that type in TFCC and come to our little island right there in Hawaii. And it's from this data that we've learned quite a bit about the dynamics of the TFCC. We know that it's equally spread amongst men and women. The age group is surprisingly 25 to 34 range if it's people north. I'm surprised to see over the 11 years that the population that is affected is over 65. We know that this happens in a lot of weightlifters, tennis players, golfers, surfers. And it's the higher incidence of the abdominal wrist, of course. The rural laborers are often missed. It's a more population. We don't see a lot of people that have medications for diabetes or heart disease, but I do see a lot of people with autoimmune disorders. An interesting discovery too was that there's a high incidence of people that develop the TFCC tear after or during a high whey protein load. I've consulted with physicians and acupuncturists, naturopathic doctors, and obviously therapists around the world to gather some really interesting insight and different perspectives to this injury. Most of the cases that we see, I've logged 40,000 cases that I've dissected personally, looked at closely. Most of them don't take medications. There's a small group of people that do, but that's too small to mention here. Most of them say that the anti-inflammatories that they take don't work. Current understanding of the TFCC is limited by the challenge of identifying it early. MRIs have a very high false negative and false positive. This is really important. There's a big difference between a Tesla 1.5 MRI and a Tesla 3.0. And even with a great MRI, they're often misdiagnosed TFCC tears. More often than not, they're underestimated. There's not a standard protocol for treatment around the world. The treatments that are provided in India are quite different than the treatments provided in the US. And I hear about them all. I look at x-rays, I look at MRIs, I look at case studies, I look at everything that these patients have experienced, and I can say that with great confidence. There's also a growing concern about the access to medicine. We know that there's a shortage of hand therapists and radiologists that can read the MRIs. We know that the hand surgeons worldwide are decreasing as population increases. We know that the access to medicine is decreasing in most countries simply because of the population increase. I have defined a weight-bearing test that uses a non-digital scale, and so far non-digital scales are easy to find anywhere in the world. I've gathered in the past 12 years weight-bearing data that has really great uses for the understanding of the progression of this injury and how it changes over a normal life. I'm here to express to you a weight-bearing test, and hopefully this will be part of your assessment of the risks.
For this test, you will need a non-digital scale and sports tape, or a wrist widget. You will use your uninjured wrist as a control. Place the hand in a relaxed position, keeping your elbow straight, lean over your wrist so your body weight moves through your wrist. Here we see a tolerance of around 70 pounds. Do the exact same with your injured wrist, but go slowly. Press through your straight arm until you feel discomfort. Here we see a tolerance of around 45 pounds. Do not exceed your pain tolerance. Next, you will need 2 half-inch wide strips of tape, cut to around 13 inches long. Start the tape at the base of the hand and wrap loosely around the wrist. Then on the second wrap, pull it tight. Leaving space for the ulnar bone, wrap the second piece of tape in the same manner. You will now repeat the tolerance test on the scale exactly as you did before. Here we see the patient's tolerance has risen to match their uninjured wrist. You can carry out the same test with the wrist widget. Put on the wrist widget as shown. Again, make sure you leave room for the ulnar bone. Pull both straps tight and attach the Velcro. Carry out the same test to ensure tolerance is even across both wrists.
Alright, so in TFCC tears, 100% of the time somebody has a TFCC tear and you tape it, you do use you need non-elastic tape. Each piece of tape is half an inch wide, or 9 millimeters. It's long enough to go around the wrist 3 times. Place one proximally and one distally, keeping the ulnar head free. Non-elastic tape. If you apply this tape on a wrist that has a TFCC tear, 100% of the time, that weight-bearing tolerance will increase, and not just a little bit, significantly. In central tears, what happens is the weight-bearing, if you have a complete tear of the central portion of the TFCC, the weight-bearing tolerance will go to about 10 kilos. And then when you put the tape on, it'll go immediately to normal, and that's significant. So it becomes also somewhat of a diagnostic assistant. Peripheral tears, it's a little slower, and complete tears of the peripheral portion of the TFCC, what you'll see is the weight bearing will go up more progressively on a weekly basis. People that have ECU tendon injuries only, with no involvement of the TFCC, you'll see normal and pain-free weight bearing. Your uninjured wrist is your control. So you have a nice control to identify your 100% number. Undiagnosed fractures are also really interesting. What will happen in those cases is the weight bearing tolerance will not change with any taping. So if your weight bearing doesn't change, if you have a significant loss of weight bearing tolerance, it does not change with tape, not the TFCC. But you want to look at fractures and undiagnosed fractures. Okay, these are important landmarks. 20 kilograms is functional. You need 20 kilograms of weight-bearing tolerance to get through light tasks, getting dressed, eating, showering, breathing. You need 45 kilograms to load it. If you don't have 45 kilograms of weight-bearing tolerance, you shouldn't be working or playing. playing tennis or getting back to load. 9 kilograms is a red flag for a great concern for a predictable cascade of events in the wrist. The lower the weight-bearing tolerance, the higher the incidence of extensor carpi-ulnaris tendinitis or subluxation. You guys following me? The longer the presentation of the symptoms, the more predictable the cascade of events are, particularly scapulohumeral problems. The longer you have an unstable or under 45 or under 20 kilograms of stability in the wrist, the deterioration is rapid. It's quick. I did a case study with Susan Barlow. This was we gathered 30 cases. We chose one. We chose this particular one because it was an early diagnosis. It was a fantastic workup by a physician at Stanford. And it was a really straightforward case. This gentleman had a MRI confirmed TFCC tear, and he started with the wrist rigid and measured grip strength, pinch, visual analog, weight-bearing tolerance. He had to wear the wrist rigid continuously and then retest it every week for stability. And over the course of 12 weeks, we followed him and then did a follow-up at 1 year, and I just did a 5-year follow-up. Case studies. He had fantastic outcomes. All right. So a mild tear, one that has 45 kilograms or above, the healing time is 4 weeks. Once they have 45 kilograms of stability, you can start stretching and strengthening program, and this makes a difference. All TFCC tears are instructed not to do bicep curls or push-ups for the entirety of their recovery. Until they get to 100% weight-bearing tolerance is when they can start doing bicep curls. They can start doing stretching and strengthening of the wrist at 45 kilograms of stability, just one as it does. In moderate tears, I define these as people with 25 to 45 kilograms, 8-week recovery time. They are not allowed to do any load over 5 pounds or 2 kilograms. They're functional, they can get through the day, but they shouldn't be loading it. They need to continue to wear the wrist rigid 24/7 all day long. A significant tear is anything under 20 kilograms, and these require 12 weeks, and they must have protective splinting at the beginning until they get to that functional place, 20 kilograms. And the splinting should be protective, but there should be nothing on the ulna head. And a lot of nighttime splints push down on the ulna head, and that harms, it slows the progress, it's painful to them, but no compression to the ulnar head at night. And then during the day, they should be protected as well. These people have lost 80% of their stability in their wrist, and if you don't protect them and get them into that functional window, they'll see that progressive deterioration very quickly. They'll see the ECU start to flux, you'll see the scapulohumeral start to have problems, you'll see the ulnar nerve start to have problems. So they need to be watched closely until they get to that functional range. TFCC tears don't have swelling. They just don't. I did a volume measurements. They don't swell. Sometimes they say they swell just a little bit. Most people say it doesn't swell. They do not have pain at night. If the ECU is present, they will have pain at night. They'll have a general ache in the morning or a general ache at night. The TFCC tears generally do not hurt at night or in the morning. Clicking is something that's not consistent, so that's not if they have or don't have a clicking, there's no consistency on the weight-bearing numbers. sick, but the lower they are, the more cascading events, the higher the clicking. But in general, the moderate and mild TFCC tears don't always present with clicking. They also don't have a delayed onset of pain. If the TFCC is hurt, it hurts when they use it. It's not something that aches, just achy. It doesn't sit there achy during the day. If somebody says they have an achy wrist, you know the ECU is involved or there's something else going on. Strengthening usually makes things worse until a certain point. And I didn't define that. I was told that over and 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 over again, that the strengthening made it worse. Of course, I can't control the type of strengthening that people do, but I do know that normal strengthening is in pronation or supination, and I also know that that leads to ECU involvement. So biomechanically that makes sense, but because of that I don't recommend any strengthening until the patient has 45 pounds of stability, 4 kilograms of stability. I do know though that strengthening is really important at a certain point, and I'm so happy to be here because to know that people are studying this. I do see a predictable biomechanics in the shoulder and the elbow. You see a tight pronator, tight anterior capsule of the shoulder, tight subscapularis or weak subscapularis. So I do see patterns of motion that are worth attention. An unexpected group of people I just want to talk about really quickly is this group of people that wake up in the morning and their wrists are non-functional. And they didn't fall, they didn't hurt it, they don't know why they hurt their wrists, but their wrists are now non-functional. When I was speaking with acupuncturists around the world, they all said that this is related to the gut. And I decided to do a study, and I had 20 very kind people follow me through this, and I had them all go get stool tests and blood work, and surprisingly, 18 out of the 20 had significant pathology in their gut, and when treated, their wrist pain went away. There is definitely a correlation between the stomach and the TFCC. People who have complete tears of the TFCC also say that it makes them sick. It makes them nauseous. I don't really know where that's going to go, but that's something that's worth talking about with patients. Also, acupuncture is probably, of all the alternative treatments that we can offer them, acupuncture is probably the best. Cortisone, most people say it doesn't help. Ultrasound, they say it doesn't help. E-stim, electrophoresis, range of motion, I get a lot of reports on that, unfortunately. The survey, I started collecting surveys from all the people that came to my site and asked them to do their weight-bearing test and gather some information. I would really love it if you guys could contribute to this body of knowledge. There's a website that you can just put in the data. Just watch the video and enter the data. Right now I have quite a bit of data. But I don't have anything from Norwich. And that's one of the main reasons why I'm in Europe, is to collect some of this data. I've got a lot of the Asian, Australian, and American market, a lot on this side. The biggest question that is difficult to answer, it took me a very long time to articulate, was when can I go back to work? When can I start paying tennis again? When is this going to be over? And I can answer that now. And that is, once you have 45 kilograms of stability in the wrist, it's livable. It took me a long time to get that. And this is really actually kind of good knowledge, because probably applies with distal radius fractures and with a lot of other injuries of the wrist that affect stability. I certainly know that this number affects, there's some interesting things about this and scapholinate. I don't know if I have time to talk about that, but yeah, okay, so dynamic stability of the shoulder is essential, and it is a diagonal. Diagonal is really important, particularly in tennis players and golfers. The lats and the external rotators of the shoulder, the rhomboids and the triceps, all in neutral. Pronation or supination is really important. There's a high incidence of the pronator tightness, and I have a stretch. It's once you get to 45 kilograms of stability, you do this on the ground. You take your arm, you fully supinate it, place it in the midline, and then lift your legs up. And that really stretches the pronator and the bicep, and that one is really important. All right. So I'm hoping to publish the normal weight bearing tolerance in the adult human wrist between ages 18 and 65 next year. The more data I have, the more we'll be able to see trends and dynamics. I would like to use this data to define post-op TFCC repair protocols. So if somebody had to have a surgery on it, it would be really nice to grade their progression through their rehab. I have a theory that ulnar variance is a byproduct of the spreading of the distal radius and ulna. And so when the TFCC is disrupted, there's a spreading, and that creates illusion of ulnar variance. I would really like to know the effects of tape on ulnar variance to support that theory that there is rather a longer ulnar bone that some people are born with that appears out of nowhere for unknown reasons, and it's actually just a byproduct of the injury rather than a cause of the injury. There definitely needs to be some discussion about the TFCC and the scapholinate. The dynamic influence of one. If you develop a scapholinate problem, typically the TFCC comes next. If you develop a TFCC problem, typically the ECU and then the scapholinate. And I don't see this with I don't see other things. You just see this pattern. And if untreated, it develops into ulnar abutment. Definitely want to understand the relationship between the stomach and the TFCC. I also want to, there is more anatomical variations of the distal ulna than we know now. There are some really interesting anatomical variations of the wrist that I think if we can start taking pictures and x-rays and looking at them in certain ways, we can define this group of people that haven't been defined. I also want to understand with the weight-bearing tolerance, how different diseases and different medications affect it. There are some medications that have popped up on the radar screen and have a bilateral influence on weight-bearing tolerance. You'll probably see this if you start asking questions. PRP is a really exciting new treatment available to the wrist, but it's got a long ways to go. I've had two people out of the 40,000, two people that have said that it's significantly affected their outcome. Everybody else, it doesn't. And I don't want to discount it, because I think it has value, but I really would like to find somebody that can standardize their treatment protocol using the weight-bearing knowledge and define protocols for productive and successful treatments using PRP. I have a small group of people that are using it on their ankles, and we're using it for high ankle sprains. And I need to mention this because I looked at the ankle. I don't know anything about ankles. And it looks exactly like the wrist. And so I think that if you have people with high ankle sprains are really difficult to treat, and I think it'd be nice to have a simple solution to high ankle sprains. And I did a very large study on distal radius fractures, and we were looking at fracture healing time. And I think that having weight-bearing numbers to define fracture healing time is really valuable. I look forward to hearing from all of you, and I hope you walk away today knowing that TFCC tears heal beautifully.